Today, I'll be talking about this automated screening and referral intervention to stop falls among older adults presenting to the emergency department. And I do have a few disclosures. I was involved as site PI on a couple studies for COVID-19 diagnostic tests during the recent pandemic. And then this work that I'm talking to you today about has been supported by the AHRQ. So I have two major goals in this talk today. The first is to make the case for using automation to improve public health screening for falls and other conditions in the emergency department. And the other is to give an overview of our experience moving one project from conceptualization through execution. I think when I started this project, now probably about 6 or 7 years ago, I really thought that I was going to be moving to becoming both an emergency medicine clinician and a data scientist. And I think what I would say now, coming out at the other end where we're implementing this project, is that I haven't quite become a data scientist, but I've had the opportunity to work with a lot of inspiring and awesome people in data science, both in our departments of computer science and biostatistics and medical informatics. But I've also done a lot more work than I thought I would in the area of computerized decision support design with our human factors engineers, and then worked with a bunch of great people in hospital administration, hospital operational leadership, and hospital quality to actually get this thing across the finish line. It's a bit intimidating to talk to this group of very august informaticians, and I think that there are certainly people in this audience who are more expert than me in each of these individual areas. So I thought that hopefully the way that I can add the most value today is to talk about my project and talk about the sort of full concept to execution narrative that we've had and our experience in getting this thing done. So because my day job is as an emergency physician, I'm going to start things off with a case. And when I'm working in that day job in the ED, I find myself writing notes like this all the time, like 2 or 3 times a day. And I'll be writing something like 78-year-old male presents to the emergency department with a fall. He tripped over an area rug that maybe shouldn't have been there in his house, fell sideways, landing on the tile floor, striking his right hip at his head. He's also got a history of a heart condition for which he takes blood thinning medications, and he takes a medication for his prostate that may increase the risk of falling. And let's say that this gentleman has a right hip fracture and a small subdural hematoma. That's a bleed inside the brain or outside the brain. Both of these injuries are incredibly morbid. And the chance that this patient is going to get back to their pre-fall state of independence and quality of life is actually pretty low statistically, and certainly not without a long hospital stay and a lot of rehabilitation. And unfortunately, it's pretty common to look and see that if this patient had been seen in the emergency department before, maybe 7 weeks ago for something unrelated, a low-speed motor vehicle accident, and we hadn't really done anything out of the ordinary there, we patched him up and sent him home. And as we see these patients over and over, the question that gets asked is, could we have done anything at the first visit to prevent the second, much more morbid visit? And so the motivation for this project is to improve public health from the emergency department. And I would argue that the emergency department is a great place to connect patients to public health interventions. There's this huge opportunity we have because of our patient population and because of when they see us. If you think about it, we see people who have less access to care in general than the general medical population, and they're seeing us at a point where they may be more able to change their health trajectories for the better, because if you're seeing me in the emergency department, you're probably having a very bad day to start out with. This opportunity to improve public health is especially true for older adults. Many older adult emergency visits are the same visits that, for random events that just occur in people's lives, but many are also sentinel events that people are having a downward healthcare trajectory and more intervention is needed to keep people healthy and independent. Unfortunately, there are constraints to doing public health from the ED, and the main one is all the other patients. The problem is that anytime we take more time away from our core mission of providing acute care to acutely sick and injured patients, we're inherently depriving the other patients in the emergency department of time that could be used to treat their acute injuries. And this isn't just an abstract tension. This is feels very real when you're on shift. If you're trying to screen patients for public health interventions, there are maybe several people in the waiting room with potentially life-threatening injuries. We need to get these people back and get them attended to. So efficiency is one of our primary motivations. And falls are important, but there are lots of other noble causes for which we're currently screening patients in the emergency department. I'm sure if you go into a local emergency department anytime soon for any reason, you'll be asked questions by your nurse at triage about your risk for suicide, your risk for alcohol abuse, your risk for being a victim of domestic violence. All of these things are very important. And there's this long list of things that objectively we really should be screening for in the emergency department. So the first question is, why is fall risk as important as all these other things that we should screen for? And I could tell you that falls are a huge problem. They're the leading cause of traumatic morbidity and mortality among adults age 65 and over, and they create a huge number of emergency department visits, over 3 million per year. Unfortunately, in Wisconsin, we have the dubious honor of leading the nation in the rate of deadly falls among older adults. And if you look at the map and the CDC reports, we're pretty well out there in terms of how high our rates of fall mortality are. At my emergency department at UW, almost 25% of older adults that we see are seen for a fall or fall-related injury. And among this 25% of patients who are seen for falls, 1/3 of these patients have been in our ED in the past 6 months before their fall. After an ED visit, patients are at an increased risk of falling for a number of reasons. So the ED visit is the right time to start to make a referral to falls prevention services. And we have fall prevention services available. At UW, we have a mobility and falls clinic, a clinic run by our excellent geriatrician team. This clinic sees older patients who are at increased risk of falls and applies a multimodal intervention, a nurse safety evaluation, a physician looking at medications, a physical therapist looking at balance and strength to try to reduce the risk of falls going forward. And in randomized control trials, this type of intervention, especially when applied right after an emergency department visit, has been found to be very effective. But before we started this project, we never move patients, we never refer patients to our mobility and falls clinic. It's just not something that, was part of our emergency medicine training, this particular part of primary or secondary prevention. So at the dawn of this project, we reached out to our falls clinic and talked about, like, how can we get more patients to you guys for falls referral? And the good news was that the falls clinic was excited about seeing referrals from the emergency department. But the bad news was, there was at least some very legitimate concern that if we just turned on some program, we were going to start referring a ton of patients to the falls clinic. Patients wouldn't be able to get seen. It would take some time to expand the resources to see them, and there would be frustration and lack of access to care. So the idea was, let's try this program with 5 slots per week at the mobility and falls clinic. So you've got 5 slots. Let's see if we can fill them, was sort of the message delivered more politely to me. And so our goal was to fill these slots with the patients who will derive the most benefit, the patients who are most likely to have an injurious fall after their ED visit. And my goal was to do it without the nurses or residents being extremely angry at me. So adding on new questions or tests was something that I wanted to avoid. There are a lot of validated outpatient fall risk metrics out there, or outpatient fall risk screens out there, but a lot of these require several questions and some sort of hands-on test, like a get up and go test where a patient is asked to get up out of a chair and we time how long it takes them to walk a certain distance. These things are tough to administer in the ED setting, and that's been a barrier to widespread implementation of these interventions in the past. I should mention at this point in time that those of you who do some falls work will note that there's a lot of falls prevention work that happens in emergency departments and inpatient units with very brief screens that is focused on inpatient falls. So falls while patients are in the hospital are something that also needs to be prevented. Unfortunately, we tested and those screens aren't super predictive of outpatient falls in and of themselves. So the strategy that we chose to use was to look and see if we could automate our screening process. And the rationale here is that we already have a lot of data on these patients. if we look at patients who are eligible for fall risk referral, for us, that's older adults who are in system at UW who already have a physician in our clinic. Many of these patients have thousands of pages of data in their electronic health records. And the question is, could we look through this data and risk stratify older adults for risk of fall without adding to provider burden by asking extra questions? And we started this project about five years ago, which may have been at the exact peak of inflated expectations around machine learning for healthcare risk stratification, depending on who you talk to. And there was a lot of excitement, and still is, and legitimately so, about this idea of, can we use the data we routinely collect on our patients to provide precision insights with customized patient recommendations to say that this person is high enough risk that they're really going to benefit from being sent to the falls clinic. And certainly in the years since, the pitfalls of machine learning approaches for this have become perhaps more apparent in the media and in the literature, and it's something that we need to keep in mind when we think about taking this type of strategy. And those pitfalls, just from a very high level, are this idea of generalizability and maintainability. Will a algorithm that works based on my data today work based on data tomorrow? Will it work at another institution? Provider and patient trust. The idea that will any recommendations that are provided by an algorithm be trusted by patients the same way that guideline-based recommendations are trusted today? And then, very legitimate concerns that models can incorporate biases in training data and perhaps exacerbate health disparities, even when they're applied by well-meaning people in a well-meaning way. So the first step in performing this intervention or getting it off the ground was to say, is it possible to figure out who's going to fall down based on looking at their retrospective electronic health record data? And like many similar projects, we started by taking a look at a curated research database that was taken from our electronic health record. So we took all patients who were age 65 years and older who visited our ED, and we looked in the electronic health record of these patients and pulled 4 years of electronic health record data. We ended up with about 10,000 eligible patients. That's patients who are going home from the emergency department, just because we don't provide referrals when we're admitting a patient, because who knows what's going to happen to them in the few days while they're in the hospital that may make that referral less useful to the patient. Have a UW PCP, a physician who's in system. That both ensures that the patients are eligible for referral in the falls clinic, and also is sort of a data validity step where we know that we have a lot of information about these patients if it's out there, if the patient has a relationship with the UW primary doc. The fields that we can pull for things like prior problems in the medical record are going to be there if the patient has a UW PCP. And among this population, we found about a 9% rate of return visits for falls within the 180 days following an ED visit. Important to note that this isn't falls overall. This is falls that require a revisit to the emergency department. That's an outcome we picked for a couple reasons. First of all, falls are underreported. Patients who don't seek care for falls often don't report them. And secondly, they're tricky to measure. If we just wanted to look at all falls, we'd have to send somebody out there to talk to all our patients after the emergency department visit and see if they'd fallen down, which is a big endeavor. So instead, we use this marker of ED visits for falls. And ED visits for falls only selects the falls that are significant enough that they may be causing significant morbidity and mortality, and also ensures that and also they're a little bit easier to measure because we have them in the electronic health record data. Also, it made it a little bit easier when we talk about the operational sell for this intervention. If we're preventing any fall, if the fall doesn't result in morbidity or mortality, that's of maybe a little bit more questionable benefit, wherein preventing a costly ED visit for a fall is obviously a very beneficial goal, both to the patient and to providers and payers. The definition we used to find falls in the data was based on both our ICD codes and chief complaint. I've got a couple citations here. We went down a bit of a rabbit hole where it turns out it's actually quite difficult to identify falls just in electronic health record data. And we've explored a number of strategies for doing that. But the problem is fall is more a mechanism of injury than it is a diagnosis. So just using diagnosis codes misses a large chunk of patients who come to the emergency department with falls. if you add their chief complaint, they often will say they fell when they came in, you catch a large number more falls. We've got some NLP approaches that we didn't use for this project that are even better, but ICD code plus chief complaint ended up being pretty good. The next step, once we have this big data set, is to pull potential predictors of falls from the electronic health record. And we did this using the Andersen model for health services utilization. For those of you who are familiar with it, is a sort of guide to say, like, what are the potential predictors that we've got? How do they fit into some sort of framework? What are the things that may potentially predict a fall? And often these projects, practically speaking, work with you take all the EHR predictors you've got, you throw them in, and you see what happens. But I think it's helpful to apply a model like this to say, is this something that I could conceive would predict a fall? And if not, why am I including it in the model? And are there glaring holes within these predictors of things that could predict a fall that we may worry about missing within our EHR data only approach that we may need to go out there and get somewhere else? We ended up with 725 potentially predictive features in the research data set. Now, this number looks huge, but remember, when we talk about features in machine learning, often we're counting each categorical variable as a separate category. So each of our lab values that we thought might be relevant, for instance, was categorized as high, normal, low, or not drawn, which is 5 categories or 5 features within the system. We tested several different sort of what I would classify as sort of off-the-shelf machine learning techniques. I had been going to very briefly go into these methodologies, but it's really tough to talk about the application or risks and benefits of various machine learning modalities in less than 5 or 7 minutes, which is about what we could have devoted in this talk to doing so. So I'm happy to talk more about why we chose the models we did and what our constraints were, although I suspect many of you are quite expert in this area already, and there are certainly other places to look for which model should I choose for which data. Model training, as I said, with this kind of off-the-shelf project, was the surprisingly easy part. And I don't say this to make a knock on people who are developing models. For advancing the science of classification is certainly, there are plenty of people who are doing this the hard way. But I would say that for a lot of these healthcare applications, what we're doing, where we take a bunch of data that we have available and we use these off-the-shelf methodologies, it's become a surprisingly routine process, assuming that you have the right technical know-how to go through a pipeline to clean these variables and then perform this test train split and try several models to see what works. Some things that we did need to make sure that we did in our case were upsampling the training cases. When you look at how these models perform, at 8.8% in our outcome, falls is a relatively rare event. So it's easy to train a model that has pretty good metrics in some ways, if it just predicts that no one's going to fall. So to combat that, when we split our data into a test data and training data, within the training data, we upsampled those cases. So the model was trained in a population where 50% of patients fell. And then in the test data, we kept the native frequency of falls. The test train split, there are a couple methodologies people use. We initially did a sort of a 5-fold cross-validation strategy, but later moved into a more chronological data splitting. The reason for this was to best insulate our model, or at least understand what the effective data drift was. So one principle that's become important for us is this idea of making sure that our test data is the most recent pre-production data, to ensure that if any variables that have changed or variables have drifted throughout the time that we have a training window, that gets captured in this move from training data to test data. The tool that we used was the Python scikit-learn kit, but there are several good kits out there. There are a lot of people who use the caret in R, and PyCaret is also very good now. In terms of evaluating these models, we used the metric that's probably most commonly seen, which is area under the curve. So the model is going to spit out for each of these classifiers a probability that a patient is going to go on to have a fall and come back to the ED in 6 months. And we have these probabilities that, let's say, range from 0 to 1, and we apply a threshold. Let's say we say if the model gives you a 50% probability of coming back, we're going to say you're positive for going on to fall. And then we look in our test data where we have cases that are labeled by whether the patients actually went on to fall or not. And we're able to draw a 2x2 table or a confusion matrix, depending on which type of jargon you prefer, where we look at the labeled data along with the model data. And that allows us to look at true positive, false negative, and true negative rates and calculate sensitivity and specificity. And let's say we have that 0.5 threshold and we draw a point where we look at the sensitivity on the y-axis, 1 minus the specificity on the x. And then we apply another threshold, let's say at 0.6. So we have less patients who are flagged as positive for a fall, which means we'll have less false positives, but also less true positives. And then we're going to move to some place where we're less sensitive but more specific. And if we apply a lower threshold, like 0.4, we're going to have more patients who are flagged positive, so more true positives and get more sensitive, but also more false positives and get less specific. And we draw this curve called the ROC curve, and then we measure the area under it, which is a measure of the overall discriminative model power of the model. So this is what we did, and there are a lot of publications that have very similar graphics looking at how well does machine learning offer the promise to solve this medical risk stratification problem. So we got these results, and it's great. You know, we have this showed us that we have an operant model. These areas under the curve in the kind of high 0.7 range sound like they're going to be pretty good. There's high hopes that we're going to be able to risk stratify patients using this model alone. But this was where I was ready to sort of declare victory on the project at first, and I thought that this was going to be like, getting to this point was going to be the hard part of this project. But you can see I'm only a little bit less than halfway through the talk. So it turns out there was a lot more that we had to do. And the questions we asked looking at these things were really, how are all of these different? And how do I move from having this data in my hand to picking 5 patients per week to send them to a falls clinic? And the first step was to see if we could turn that 0.78 area under the curve into something that's a little bit more understandable as we move on from the data science area to talking to people who are operational leaders at the hospital about why we should be using this model, who tend maybe not to think as much in areas under the curve and more in these hard sensitivity, specificity at a given cutoff. And the question is, where are we going to put the threshold for this model? And how can we quantify and communicate that trade-off I mentioned between sensitivity and specificity as we move through thresholds in a given model? I have 2 ROC curves here, and you can take my word for it that blue has a slightly higher area under the curve. But if we're looking at our falls model, where our goal is to only pick 5 patients per week out of about 50 who come in, who are potentially eligible, how are we going to, which model is going to be better for us? And as we flag less and less patients by moving the threshold up on our model, you have to be at higher risk to get flagged. We move towards this leftward part of the ROC curve. And you can see the red curve, even though it doesn't do as well overall, actually outperforms the blue curve in this area, where if we're talking about at a 90% sensitivity, sorry, a 90% specificity here, the sensitivity of blue is only 0.2, while the sensitivity of red is 0.4. So just using area under the curve alone was probably not going to be enough for us. And a concept that we wanted to pull into this was the number needed to treat. For those of you who aren't familiar with it, number needed to treat refers to, for any theoretical intervention, the number of patients that we need to do something for to prevent one bad outcome or to attain one good outcome. So in this case, it's the number of patients we need to refer to prevent one fall revisit. And this is a number that is very easy to communicate to clinicians. In other areas in my clinical life, I hear about number needed to treat a lot, and it's something that the physicians who are actually treating the patients in the ED view as a very internalizable number, and something that we can kind of fit in our heads about, like, how good is this treatment as compared to other treatments that we give. And the number needed to treat is the inverse of the absolute risk reduction. So if I reduce the risk by 20% or 1 in 5, I would need to treat 5 patients to attain one desirable outcome. And we can estimate the absolute risk reduction by looking at the relative risk reduction for an intervention multiplied by the absolute risk. And looking at what we've already done, we have this data in front of us. So the relative risk reduction is a feature of the intervention we send the patients to. And based on a now pretty old randomized control trial looking at the referral of emergency department patients to a clinic that performed a very similar intervention to ours, we can estimate our relative risk reduction at 0.38 for a clinic visit for future falls among a patient referred from the emergency department. And we know we can actually find the absolute risk reduction in our test data. When we apply a threshold to a model that's run through the test data, we know how many patients were flagged as positive for falls. So let's say we have a data set in which we flag 10 patients test positive, but our data is labeled in the test set. So we know that 50% of those patients go on to fall. We know that the absolute risk in our flagged positive patients is 0.5. So we can calculate the number needed to treat. If we're able to winnow our population down to a population that has a 50% chance of falling, our number needed to treat for an intervention based on this falls risk score is 5.3 patients referred per fall prevented. Apologize for the typo. And 5.3, for the record, is pretty good, especially for a preventative measure. If you look at other things we do within medicine, I would argue that 5.3 patients per intervention, per 5.3 patients to prevent one fall, it's hard to argue that that's not a good referral. And what we did was we then transformed the ROC curve into a number needed to treat versus number referred per week curve. And you see, if we just refer everyone, the native risk of falling in our population, if we don't do any screening, is 0.088. The number needed to treat if we referred everyone to the falls clinic is 30, which I would argue is less of a good deal in terms of, do we really want to refer 30 people for each fall that we prevent? Not to mention the fact that we can't refer 50 people per week to the falls clinic because we don't have the capacity to do so. So we're going to have to put a threshold somewhere. And this curve gives us the okay, so if we put this threshold in around 5 per week, we end up in this slightly lower number needed to treat range where we want to be, somewhere below 10 or in the 10 range. Here's another number needed to treat versus referred per week curve from our publication with some error bars where we put in error that we estimate around the effectiveness of the intervention. And we did build a toolkit, which you can go to at this link here, that allows you to download a package to transform ROC curves into these number needed to treat curves if you're interested in doing so for any intervention that you're considering. So this is good. We've gotten a little bit further. We've gotten from just having these abstract ROC curves in our hands to having a having some sense that this, if we operationalize this at a threshold, we think that an intervention will be effective in preventing falls. So what are the next steps that we need to do to move from a predictive model to a predictive solution? Something that's actually going to exist in the real world. And there were a couple hurdles we still needed to go through. The first is operationalizing that algorithm to go from taking a look at a nice curated research data set to working in our electronic health record system live in real time. The second is designing a computerized decision support workflow to support this recommendation and get it to clinicians. And then the third is getting this thing approved by whomever needs to approve it. Like, once we have this thing, who gives us the green light to turn it on? What are the legalities around this? What does the hospital think? We had to navigate that as well. So the first and probably easiest of these three were these pure technical challenges. And like many of these projects, we started with something that was a curated research data set that occurred several months latent to the actual healthcare. And that was pulled from an operational reporting database, which is called Clarity. If those of you are familiar with Epic, Clarity is a SQL-based operational reporting database that's pulled down from a transactional database that exists in real time. The transactional database in our case is called Chronicles, is the Epic terminology, but most modern electronic health records function this way. You have some sort of transactional database that's keeping the lights on and keeping things running and very facile at entering and spitting out information for patient care tasks, and that is downloaded to a easier to query reporting database on some fixed interval. And then people around the system are taking out from that reporting database, carving out other research databases that maybe are augmented by other systems. And one feature that people talk about is this idea of time travel, where things that you think when we perform this, when we derive the algorithm, we only want to use data that existed at the time the visit existed, and we tried to do a good job of that. But it turns out people are going back in and changing diagnosis codes for months afterwards. So it turns out that some of the diagnosis codes we thought were entered at the time of the ED visit are actually entered months later. So we need to adjust our algorithm for that. Furthermore, when you're going into a real-time database, you can't just throw out observations that don't have data, because you're not going to give patients a score. And thirdly, the 725 features I mentioned is a really big burden to maintain in real time. Each of those features is another variable that we're going to need to feed into our system, that we're going to need to have someone in charge of looking at every once in a while to make sure it hasn't changed. And that could screw up the output if somebody decides we're going to change the way that we document this variable. So we put several technical solutions into place to take these. We used a cloud-based platform. We used the Epic Cognitive Compute platform, although since then we've used other secure cloud-based platforms for similar projects. And it basically, the electronic health record, it pulls variables through an API from the electronic health record as they're created in real time. It, every 15 minutes, calculates a score based on the algorithm for every older adult who's in the emergency department. And then it returns as a variable back into that operational database a score and model information. We can pull in SHAP values or other values as flow sheet rows in the electronic health record. We cut down pretty significantly the number of features we had. Our research goal was aimed purely at like getting the maximum discrimination we could. But once we balanced that with having simplicity of a model, it turns out many of those 700 features were not particularly informative. And we were willing to trade off a slight change in our number needed to treat to give up a large number of features. And initially, we did take a little hit where our number needed to treat in the area of our referral threshold went from 10 on the research side to 12 on the operational side. But since then, refining the model, we've actually gotten back down to an equivalent performance to the research model in the operational model. We also have, as I alluded to, retrained and revalidated the model in production data. And this is something that's very important. No matter how close you think your research data is to true production data, small changes in the way that these variables are annotated or entered into the system may have big effects on model performance. So it's been important to make sure that we revalidate the model on immediate production data before going live, as well as continue to monitor the model as it goes out into real time. Now, in terms of tasks that we have, now we've gotten one step further, where we have the model firing on patients in real time and returning a piece of information into the electronic health record. And that piece of information is that 0 to 1 number that's the model output that we can then apply the threshold to. And the goal now is to design a clinical decision support workflow that will actually get this into the hands of clinicians and get them to facilitate referrals for falls patients. And if you look at the literature in clinical decision support, especially clinical decision support in the emergency department, the overwhelming message that you take away is that it's pretty easy to make something that actually works in terms of decision support that's going to guide providers to do the right thing. But that doesn't necessarily mean that you're going to get uptake. One of the real important things is having something that works, that people actually use in their day-to-day workflow to realize the benefits. There's a lot of literature suggesting that, you know, building certain things works if physicians use them, and then a lot of literature suggesting that, like, if you query physicians and do some survey work, you're going to find that people love using these things. And that's what we had as well. You know, whenever we've tested out clinical decision support in the past, physicians always say, yeah, this is a great idea. But even if they think it's a great idea, that doesn't mean that they're going to use it at work if it doesn't work in their workflow and it isn't designed to actually make their lives easier and make them better in a way that's like very palpable on shift. And so this is where we pivoted from, talking with our, colleagues in computer science, informatics, and brought in our human factors engineering colleagues. And again, we refer to a theoretical framework to try to move this model design process forward. And because Dr. Pascal Carrion is one of my mentors, the model we used is the SEEPS model, or Systems Engineering Initiative for Patient Safety. And again, the useful thing about the model here is it gives some framework to our design sessions where we make sure that we're explicitly considering all the inputs that could potentially throw this thing off. What we're proposing doing is adding a technological tool to the existing electronic health record, a CDS system to refer patients for falls. And we need to make sure that none of these other factors, time, pressure, physical environment, other patient care tasks, are working against that tool or are reasons why that tool is going to fail and people don't use this workflow. And that was the theoretical model that we used. And in conjunction with our human factors engineers, we went through a series of design steps. And the first design step was to analyze prior interventions. So look at other things people had done to screen for falls. And I alluded to this earlier, but the overwhelming message we got is that people, in general, the biggest barrier is this idea of time and resource allocation, that people want to screen for falls, but that within the confines of a busy emergency department, we're not going to be able to do something that adds time to workflows. We also, both through surveys and interviews, talked to our clinicians and got a very similar message. People think that this is great. People want to refer to the mobility and falls clinic and think that it's important for their older adult patients, but they don't know that they're going to be able to incorporate extra steps into their workflow to do it. So then we kicked off a series of interdisciplinary design sessions where we had stakeholders from all the relevant groups. This is the clinicians in the emergency department, both physicians and nursing input. We had input from our colleagues in IS who are actually going to like build this thing and tell us what is possible. We had the design experts from engineering there as well, people from quality in emergency medicine, and we, at that point in time, did an iterative design process where we came up with a workflow that we thought was buildable, that we thought would fit well in the workflow using all those design constraints within the model. We then took it to patients for feedback, where we learned we actually got some very interesting insights from our patient feedback. Providers were surprisingly trusting of this model in terms of if I say, like, if the model comes up and says this patient's at high risk for a fall, people will say, oh yeah, it sounds like this person's probably a high risk for a fall, we should send them. But the initial patient facing documentation that we developed was like, you've been selected by this cool algorithm for as increased at falls risk. People reacted very poorly to. They want their provider to be providing a referral as opposed to some faceless computerized algorithm. So and in this system, we want the algorithm to augment provider decision-making. So we emphasize in our patient-facing materials that while you might have been identified by an algorithm, it's your provider's choice to refer you to the falls clinic. We then created mock-ups of our design support in test environments, which allowed us to run them through for a heuristic evaluation, which is a formal run-through where the design experts take a look and see what principles we're following and which ones we're violating, which resulted in another iterative design, and then a final usability review with physicians in the test environment. And obviously, it didn't happen in this like nice, clean 1 through 7 step format. The design process, when you kind of like looked at what was happening in parallel, was more iterative than that, where we have our collaborative design sessions feeding into this prototyping and rapid cycle testing, along with the more implementation focused strategies of looking at the patient and providers who are going to be use this feedback, both of which refine the content to get to our final project, which launched. We launched the project, I think our official live date we're now calling, we had a brief date right before COVID started, and then we turned it off almost instantly because the clinic was closed. We restarted it this spring, and it's been running throughout the summer. And the current algorithm works something like this. When patients arrive in the ED, the algorithmic screening is performed every 15 minutes. So scores are created for every patient who is age 65 and over, but the score is only really valid for those patients who were in the derivation cohort, patients who we know are going to be discharged, who we know have a UW-PCP. And there are a couple other eligibility requirements that are all assessed at that time. If the patient is eligible and they are high risk, the clinical decision support fires to the provider at the time when the provider is creating the patient's discharge instructions. Alerts the provider that this patient's at high risk for fall. Do you want to refer the patient to the falls clinic? The provider makes one click to place a falls clinic referral or declines. If the physician declines, the patient gets usual care. If the physician accepts, the referral is made and order is automatically placed to the falls clinic, which means that falls clinic staff will come back to these patients to schedule the appointment soon after the visit. And a text is also put on the patient's after visit summary, which is the documentation that the nurse hands to the patient at the time of discharge. The nurses see that documentation, and we've done a lot of outreach with the nurses to use that as a key to educate patients about why they were selected for this program, the fact that their physician chose to select them along with the algorithm, and what to expect from the schedulers coming forward. And at this point in time, once we turn this on, we moved from this world of like more academic human factors and design into the world of hospital quality, where you can envision this this project as very similar to a lot of different quality improvement projects that we have ongoing at the hospital. And you'll find plan, do, check, act, or plan, do, study, act cycles are very very prevalent in the way that people think about these things. And certainly once we turn this intervention on, we didn't just stop doing something and just let it go into space. We continue to get iterative feedback to look at rates of referral, and we've been making interventions throughout, changing the way that the intervention is displayed so that the pop-up is more visible to physicians, doing more nurse education to try to improve the way that nurses discuss the project with patients, and we're continuing to improve that process. And you can see I have another link here if anyone's interested. We have a toolkit that looks at how the life cycle of a predictive model that I've discussed thus far fits into the focus PDCA quality improvement schema for those who are interested. And that's available. It lets you kind of fit in to try to kind of translate from this from combining these worlds of informatics, human factors engineering into discussing these things with the people who are doing this stuff on the ground in the hospitals, the operational leadership. The other question that we asked is, who tells you it's okay to turn something like this on? One question is that of legality, like what does the FDA have to say about that? And the FDA is still in sort of a draft guidance phase. But it seems like the FDA is actually quite interested in regulating computerized decision support tools like this. And the relevant language is that if you've got a decision support tool that provides a diagnosis or a diagnostic recommendation, and it just spits it out like a black box, you have a medical device, and you need to go to the FDA to get that approved and get an IND. And that seems like, I've never done it, but I've heard it's quite laborious. And for a couple of reasons, would prefer not to automate that step anyway. If, on the other hand, rather than just automatically creating the referral or telling a physician that they have to create the referral, you allow the provider to review the individual basis for the recommendation, then your decision support is not subject to FDA guidance, at least in the current draft guidance. So the idea would be that if my thing says, we think your guy is likely to fall, please refer them to fall clinic, that's probably a device. If we say, we think this patient is likely to fall because they are 88 years old and they use a walker and they're taking 6 different medications, that is not a device, because it's saying to the provider, okay, that sounds good. So in our current model, there's a link through the BPA that providers can look at that basis of why the patient is able to fall. In our early iterations, that was just, you're able to just look at the model, and we weren't able to provide those values. And now using a SHAP value return, we're able to actually say, like, what are the most important values for your patient in this model. And then once we decided we were pretty clear from the FDA standpoint, the question is, okay, so who in our health system approves these things? And at UW, as I would imagine it, in many places, we have a clinical decision support committee, which looks at clinical decision support and decides whether, you know, these guidelines are well-based and what gets turned on. And that was the initial road that we went through to start this project. But we, with this project, along with a couple other projects, were able to shed some light on the fact that with machine learning and artificial intelligence, it's maybe a slightly different ball of wax than guideline-based decision support or other, you know, sort of pop-up decision support tools that we use. And there was the recognition that we needed a new committee to look at our use of machine learning and AI in healthcare that comprised of not just clinicians and subject matter experts, but also people who were building these things and the experts in the technology itself. And the cool thing about this is we were able to engage experts from outside of purely the health system, but people who were in the broader university who were experts in technology from our biostats and medical informatics department, experts who in health equity, people who are going to have an expert look at the ethics of these models, which with the idea of reviewing any machine learning or artificial intelligence based model which touches patients and ensure that these models are approved and then are put on an ongoing review and maintenance cycle, so that as an institution we have knowledge of what's out there and in some oversight and ability to corral all these models into to make sure that the playing field is level in terms of how we look at each of these models. And the guiding principles that we talk about are for these predictive models. I threw up here, it's a pretty wordy slide, but the thrust is that any model is going to need to be validated in our own data, that due to the nature of these models, it's very important to run these models in pre-production data that we have to see it, to make sure that the results that we're getting for our patients are the ones that we expect to be getting. That the model is evaluated based on measures that matter to the clinicians and patients who will be using the model, and that those measures are going to be used not just to approve the model for initial use, but also to monitor the model once it is scaled out. And also that model is constructed into a solution in such a way that it's going to follow all of our previous guidance on decision support. I put the 5 rights up there, but I think that's this idea that these models are going to spit actionable information to the people who can act on it is very important. And then also that these models are going to follow our basic principles of healthcare ethics as they are rolled out, and that we're going to continue to monitor models with a specific eye towards this. All right, so we've got the governance up, the model's been turned on. The big question is does it prevent patients from falling? And there, we're not quite there yet. We are currently measuring and improving our appointment completion rates. During the COVID second wave pandemic over this fall, our completion rates have been unfortunately pretty low. Once people get an appointment, they're often not as interested in going, which I don't know that I can totally blame people for, given the current state of COVID in Wisconsin. We're currently working on a number of interventions to improve that referral rate, and hopefully as COVID calms down, that's going to improve as well. And then we're in the process of building a hybrid implementation effectiveness trial where we're going to roll this algorithm and model out with some design adaptations to other sites within our health system and measure the overall effectiveness at all 3 sites in preventing falls. So more to come on that as we complete that work. So I am done now. I can stop to take any questions. I do want to acknowledge that certainly this was not my project alone, but that I've had a huge team of research mentors, collaborators, and especially partners on the UW Health in the data science team who have helped to bring this thing to life. So thanks for your time, and I'll take any questions.
Thank you, Brian. questions?
Yes, I have a question. I'm Xiaoshun Li from Biostat Department. This is a very interesting talk. I have a question regarding referral. For people who in the field doing the referral, they still need a numerical threshold, right? So I'm wondering, in your process, you did upsampling. So the prediction number coming out of the model, they're not true probabilities. So the first question is, do you do some sort of a calibration so that they're true risk probability? Second is, how do you arrive at a numerical threshold for high risk and low risk?
So that's an excellent, excuse me, that's an excellent question. There are, just stop my screen share for a second. There are, so there are a couple things wrapped up in how we choose the threshold. So first of all, while it's technically possible, certainly, to compute a patient's risk from the model of falling based on data and communicate that to the falls clinic, but we don't currently. And the paradigm before this model existed, right, is that I see a patient and I decide that they would benefit from falls and I place the order. And once the order is placed by the treating physician, the falls clinic gets the referral, and then the falls clinic staff calls the patient, and their assessment tends to be focused more on like, is this person an appropriate referral as opposed to what's their absolute risk? And an appropriate referral regarding like, can they be seen in this clinic and do we think that we can help them? And they have an existing process for that. So the falls clinic staff who do these referrals know that the referral came from our program as opposed to anywhere else because of the way that we do the order. But I don't believe that they're not differentiating between patients, say like, oh, this person got referred, but their score was a 0.99 versus this person's score was a 0.77. So I'm less excited to get this person into the clinic. I think it's a good idea in terms of like some of these referrals probably are more urgent than others, but it would definitely complicate things on their end. So once somebody's over the threshold and gets referred, they all get treated the same. They're high risk, they're going to get a referral. In terms of how we choose the threshold and like what is high enough risk, a lot of that is actually determined by the needs of the clinic. And I think that's one of the coolest things about this intervention is this idea that in one sense, like one way to approach this would be to say like, what is the risk benefit that we think is the normal number needed to treat? Like where do we think this is an effective number needed to treat? And maybe we say 10 is the number needed to treat. We want to refer everybody over 10 and then build a falls clinic that gets a number needed to treat over 10. But the problem is it's surprisingly noisy in terms of how many patients come in a week who are going to be at a certain risk threshold. And the operational constraints are if you build a clinic, you need to keep it open and you've got a certain amount of space. So what we do is we try to peg it at, let's pick the best, let's use what we've got, which is 5 slots a week. And if we find that we're not referring some really high risk patients because we don't have enough slots, we should build more space at the falls clinic and then come back. And if we find that we're not filling it, we can raise that we can lower that threshold and include some more patients who are in that lower risk who can benefit from the intervention. So right now, most of the threshold selection is operational, but calculating the numbers needed to treat at a given threshold keeps us honest in that we're not like making silly decisions just to fit our operational goals.
We have another question on the chat. Brian, can you read from there? Or?
Yes, what if somebody's already been referred in the past? This is an excellent question and actually like the kind of problem we talk about in our weekly meeting. So the answer is right now, the falls clinic staff just takes the patient out of the referral process because they've already been referred. It's thought of as like a one-time referral. And there are patients now that we've been running this thing for a couple of months. There are a couple like really high-risk patients who we see an awful lot, right? And they just keep popping up. And we are currently actually working to find the best way to exclude those patients from the actual pop-up. Like we really, in theory, we should refer them once, and then we'll actually keep referring them until they interact with the schedulers. Like if they cancel the appointment, we'll refer them again. But once they've had an appointment on the schedule, they shouldn't get referred again. And we're working to make that happen electronically instead of having that pushed to the schedulers.
I think there is one more.
are the decision curve analysis and model interpretability available to the referring physician and the fall clinic? So yes, in that the falls clinic has definitely seen all of this data, and the referring physician can read as much as they want about the model. Like there's a small pop-up that there's a small pop-up that says your patient's at high risk, and it says click on this to review the model, and it shows the model, and it shows the output of the model in terms of how high risk this patient is compared to other patients. We don't currently show like the overall, like your patient has X risk of falling, but it's certainly a good idea, and something we could consider going to in the future. I think as the models get better calibrated and the newer models are better, I think we'll have more, I guess it's that question of like, do we want to pick who's high risk and who we want to send and just tell people they're high risk, or do we want to give people all the information about their exact risk levels and let people make their own decisions?
And that will be the last one, Brian, from Ryan.
Oh yeah, sure. So including EMS run reports to capture non-transport falls. There are a lot of falls that are not transported to the ED. That's a really good idea. I think if we're looking for extra patients to, you mean as an outcome? Like right now we have this like clean training outcome, which is return visits to the ED for falls. We're actually looking at incorporating EMS data into our, there are some projects to do this, so it's technically possible. We'd have to think about how to put that in as both an outcome and as a risk factor for future falls. Because if somebody's had a bunch of runs where they weren't transported, they're certainly at high risk for falling and being transported in the future. And hopefully we'll be able to bring that in. It's still not quite technically possible.
Well, I'm sorry that we are at the end of this time here, but it was such a wonderful time listening to what Dr. Patterson had to say. At least for me, I guarantee it's for most of you. I was thinking all the time, if I had to convince someone about what learning health systems are, I would put this this presentation and say, look how it works. And people starts to understand how critical it is to keep this wheels of the learning health system spinning correctly with all the pieces. And you see there are many sub wheels inside the big wheels. So it's a really cool way to show things based on a case. And cases are easier for people to understand. Brian, it's a wonderful work. Thank you so much for putting together this brilliant presentation, and hope to see you again soon. And thank everyone for joining.
Well, thank you all for having me. It was great to be here. Thanks.